All right, so we are shifting gears and we are moving into our final session of the day before we jump into our expo. And it is a conversation on fibroid awareness. We are joined by Dr. Adrienne Galang, who is an OBGYN. She's passionate about caring for women at every stage of life. Okay, she has earned her medical degree from New York Institute of Technology and completed her residency at Wyckoff Heights Medical Center. And she's coming to us talking about fibroid awareness, but part of her specialty is also dealing with women who find themselves in some really stressful and strained situations as it relates to their gynecological health. And we're grateful for her passion in this field. And we want to talk to her about awareness. You know, what exactly fibroids are, what can we do about them, what treatments are available, why women of color seem to be plagued with this issue. And we're at your feet looking for some guidance in this space. We'll open up for some conversation. We're going to let her do the training, and we'll open up for conversation at the end. And we'll also be joined at the end by one of our SLIM clinicians who will pray us out in regards to fibroids, and her specialty is fibroids and endometriosis from a mental health lens. Okay, so we'll circle back in with Shakira at the close. Okay, so Dr. Galang, take it away. Thank you so much for being with us.
Hi, good afternoon, everybody. Can you hear me okay? I'm a little
we can. We hear you loud and clear.
So Liz is going to help me with the slide deck for me. But my name is Dr. Adrienne Galang, like she introduced. I'm one of the OBGYNs at White Plains Hospital. I'm part of White Plains Physicians Associates, and I've been asked to speak about fibroids, which is a ginormous topic. I'm going to try to, get to the key points here. A lot of what I'm going to talk about is kind of physical, but as you also explained, Dr. Kim, there's a whole lot of other things to it. There's a lot of mental, psychological kind of aspects to fibroids, but I'm going to give a brief introduction of exactly what fibroids are, symptoms that, may come about from them, and then broad strokes on treatments. With everything in medicine, I guess, and especially fibroids, a lot of it is personalized, right? Where are you coming from in your life? What are your future plans? Far in the future, closer by. So I'm going to treat it a little bit as if you were coming into my office and we're kind of talking about, you're a new patient to me. We're going to talk about your options. So it'll kind of act like that. But if anybody has any questions at the end, I'll try my best to answer. If not, I'll get you the answer somehow. Okay. You can go to the next slide, Liz. Thank you. So fibroids are the most common pelvic tumors in women. They're over 95% benign, so that's at least a good thing. They're made up of the smooth muscle cells and the other types of cells that are made up in the muscles of the uterus. So, they come in all different shapes and sizes and a bunch of different places they could be. This initial cartoon, kind of looks a little funny, but they can honestly happen anywhere, and that's only parts of where they come from. You can go to the next slide, please. So this is more like a little bit more of like the technical of where these fibroids can be, but broad strokes is they can either be subserosal, meaning closer to the surface. That's like your 7, 6, and 5 on the screen. Intramural, meaning they live inside of the muscle of the uterus. That's your 4, 3, 2, a little bit of 1, but mostly 4, 3, 2. And then submucosal are really the 1 and 0. And this matters a lot when we're talking about this in the office as to what your symptoms are, what we can provide for you in terms of treatment, what's the best option for you. So, when we initially meet you guys, some of this happens, you can't always see this just from talking. I'll get into later some of the imaging modalities that we use, but these are just, if you think about on the surface of the uterus, in the muscle of the uterus, and then in the actual lining of the uterus, and it'll make a little bit more sense as to what kind of symptoms you can get from it. You can go to the next slide, please. So risk factors, there's a whole lot of them. This is probably just a percentage of that. Parity means, how many pregnancies you've had before. Studies have shown that the more pregnancies a woman has had, it decreases the chance of fibroid formation. In terms of menarche, meaning the first time a woman has her period, if it is earlier on in your life, so less than 10 years old, that increases the chance of fibroids. The idea being you're longer in your menstrual cycle life. So the longer that you are able to have all this estrogen come into you, the more likely a fibroid can form. In terms of hormonal contraception, a low dose oral contraceptive, so a birth control pill, though it does have estrogen and progesterone in it. You would think that that feeds these fibroids. The studies have shown that it doesn't quite show like a large growth in the fibroids. Certain diets, so diets really, really heavy in red meat can increase the risk of fibroid formation. Vitamin A can decrease that risk. Alcohol, they say, especially beer, that can increase the risk. Whoever made that study, they found that. Smoking, there used to be an association of decreasing the risk of fibroids. Not that I'm going to say you smoke and now you don't get a fibroid, but more recent studies have kind of debunked that. So no real connection with those two. We're going to get to race and ethnicity then. So for Black women, there is a 2 to 3-fold greater incidence of fibroids versus white women. And in Black women, in the Black population, they are more likely to have symptomatic fibroids. So some people will incidentally find a fibroid. You got an ultrasound for another reason, and you see a small, like a 1 centimeter fibroid there. But in terms of symptoms, I have all this bleeding. My periods are super heavy. They're very painful. My whole belly feels really kind of bloated all the time. It's a higher prevalence in the Black community. And then in terms of genetics, you'll also often hear, and I hear this all the time in the office, a young woman comes into the office, she says, my grandmother has suffered from fibroids. Do I have them too, or will I develop them? My mother has had them. And it does seem to show that there is a little bit of a familial disposition, but in terms of finding an actual gene that targets that, they haven't found that as yet, if they are. But for sure, and I'm sure you've heard enough stories that, my mother, my aunts, my grandmother, we've all had these fibroids. There does seem to be a bit of a link to that. Next slide, please. So symptoms, like I said before, you could be asymptomatic. I had to get an ultrasound because I just found out I was pregnant. They found a 1 centimeter fibroid, right? Not always will that have a symptom. You just happen to find it because we got an ultrasound for you. That's one of the, symptoms. Heavy prolonged bleeding is probably one of the more common things. Again, a woman comes to me in the office, hey, doc, I have terrible periods. I bleed for a very long time, large blood clots. I'm bleeding through pads and tampons. That's one of the more common symptoms that can come from fibroids. The location of where the fibroids are can kind of give you an idea of how bad the bleeding could be. Those submucosal fibroids are the ones that live in the lining of the uterus. Those are often more connected with heavier bleeding because they're in the actual lining. The thought of why fibroids can cause heavier bleeding, they're this piece of tissue, an extra piece of tissue in the uterus. The uterus gets a lot of blood flow. So these balls of muscle, essentially, they are directing a lot more traffic towards the uterus. So that's the idea of why you get more bleeding when you have these fibroids, and especially in that endometrial canal or submucosal area. The bulk symptoms, so meaning it's taken up space, your abdomen can only allot for so many things. So oftentimes people will come to me saying, they feel like they're urinating a ton, or they can't really empty their bladder as much, or suffer from constipation. If you have a large fibroid in the back of the uterus, it's pushing on your rectum, it's pushing on your bowel. So it can be hard sometimes to have a bowel movement. So those are some of the bulk symptoms that can present. Pain, of course, right? Oftentimes associated with periods, but can also be from other things. So painful periods, again, because there's just this extra, tissue in the uterus that not everybody has. Painful intercourse, also another common complaint. Every sexual partner I have, there's always this pain with intercourse. It's more common when these fibroids are at the top of the uterus or in the front, just because, with movement, it's pushing up on organs that are above or right in the front. It's just, it's more prevalent to feel that pain when it's happening. And then fibroid degeneration. So often, more times in my pregnant population, I do have a number of, we do see a number of pregnant women with fibroids. And, the pregnancy is then also competing for that blood flow. So if you imagine you're cutting off blood supply to anything, any organ in your body, any whatever, it's fighting with the pregnancy. It starts to take away that blood flow from the fibroid. So eventually that's going to lead to pain. And then in pregnancy, and I'll talk about that at the end, what we do for that. But that's one of also the common symptoms. And then fertility or obstetric complications, that often is, how we end up finding fibroids also. So also oftentimes in the office, a patient, I've been with my partner for X amount of years. We've been trying for forever. I don't know why it's not working. When you have these fibroids that live maybe close to the entrance of the fallopian tube, right? We need the fallopian tube to be able to bring that pregnancy into the uterus. Or if you have these submucosal fibroids, the ones that are in the lining of the uterus, where this potential pregnancy needs to attach to. If it doesn't have like quite the hospitable environment for that, it can often lead to difficulty conceiving, but also some people will have recurrent miscarriages because of that. The pregnancy will implant in an area where the fibroid is, and it's not as hospitable as the regular wall of the uterus. So you'll often see that as how we find these fibroids. And then also in pregnancies, sometimes, we got pregnant, the baby's growing, but if that fibroid is in a location where it kind of makes the baby just have to move around it, it's not quite hurting the baby, but sometimes that's why babies are breached, let's say, right? If they can't kind of move into a space that makes the head down because there's this block of tissue that's in the way, sometimes that's why we lead to like breech pregnancies and things like that. Next slide, please. So diagnosis is much like anything else. You get a history and a physical exam. Hey, what are your symptoms? I'm having a lot of bleeding. I have a lot of pressure in my abdomen. It's been difficult to get pregnant. Any kind of history. You get a full history of that. How bad are the symptoms? How often do they last? Is there anything that brings them on? Do they happen all the time? Are they only during your period? Right. So there'll be a litany of questions, and that's only just a sampling of it all. And it just depends on what the patient is bringing, what kind of symptoms they're having as to how the history goes. Physical exam, an abdominal and pelvic exam makes sense, right? You feel the belly. Sometimes these fibroids get so big, you can feel them actually on the abdomen from the external. Oftentimes we will do what's called a bimanual exam, where I can feel into the vagina and also on top of the belly. And you can almost feel that uterus in between your hands. You can give an estimate of how big that uterus is. A lot of that is for, kind of surgical planning. If we're talking about, how big we think something is, what options we have for you. Those pictures on the bottom there, to the left is an ultrasound image of a fibroid. The uterus is that top part of it, and then that like almost darker circular part below it, that is a fibroid on an ultrasound view, versus an MRI on the right side. MRIs we often use, and I'll talk about that later for why we use it, but you can see these like darker areas, circular areas within the muscle of the uterus. So you can see kind of how big those fibroids are, where exactly they're located. So that's part of the imaging that we also do, which becomes important because we can only feel so much. And sometimes people, are uncomfortable with the vaginal exam. It's hard to feel everything around. But these images give us a lot of information in terms of our treatment options for you. Aside from just the regular pelvic ultrasound, there is a special kind of ultrasound called a saline sonogram. It's not a very comfortable ultrasound. Not that any of these ultrasounds are probably comfortable, but in the lining of the uterus, where those submucosal fibroids mostly live, when your uterus doesn't have anything in the cavity, like a pregnancy or something, it's a collapsible tube. So it kind of just sits close together, the front and the back of the uterus, just like what that picture on the ultrasound shows. If we're worried about a submucosal fibroid, what the saline sonogram does is it introduces some fluid into the cavity. So it distends that cavity a little bit so that you can see the outline of the lining of the uterus, and it gives you a lot of information. A lot of fertility doctors use that. So it's one of those kinds of modalities. Another way that we can actually look into the lining of the uterus is called a hysteroscopy. Some offices have that option in the office. Some places you have to actually go into like a surgical center or an operating room. We introduce a small camera into the cervix through the vagina, introduce water just like with the saline sonogram so that we can distend that cavity, and then we can actually look around and see what we see inside. Is it a fibroid? Is it a so the hysteroscopy is another way to do that. It's a little bit more invasive than an ultrasound. Takes a little bit more planning, but that is a way that we can look on the inside of the uterus. And then we talked about the MRI from before. Next slide, please. Okay, so treatment, right? This is kind of the bigger part of the talk here. There are a million different ways to do everything. There are, what you kind of want to see are what the patient, what the symptoms are and where the patient is in their life, right? So the bigger, I guess, groupings of things to look at is, does the patient desire fertility or not, which is another way of saying kind of where they are in their life. Are we a 20-year-old who has never had a baby before who really wants to have one? Are we a 60-year-old who's already had their babies, we're postmenopausal now? Are we in our mid 30s and still really want to try for a baby, and even though we have these big fibroids there? So big picture is, are we trying for a pregnancy or not? And then what symptoms are we having? And just to use the broader strokes here, that's bleeding and pain. The next slide, please. So we're going to start with the arm of does not desire fertility. So these are my 42-year-old woman. She's had her 3 kids. She's already tied her tubes. I don't want kids anymore, but I want these fibroids to be fixed, right? Or my 65-year-old, I have a lot of pain from these fibroids. I'm not bleeding, but we're not going to use this uterus for a pregnancy anymore. The first line of defense is medical, right? When you talk treatments, a lot of it is risk-benefit profile. Surgery and those kinds of things have a lot more risks involved. So start with medication. The first tier of medication are the combined hormonal contraceptives. That's your birth control pill. That's your progesterone. So that's your could be a birth control pill, right? Easiest thing to start and stop. There are, of course, risk and benefits, adverse reaction things to that. That's a conversation that you have with your doctor if that is an option for you. It's not as invasive invasive is a big word, but placing an IUD can be pretty painful in the office. If you wanted to try some type of a pill or maybe the vaginal ring, which can also have both estrogen and progesterone in there, that is one of the options that we use to help to decrease the bleeding that happens if that is the main complaint. Progesterone IUDs, that's your Mirena, your Kylena, your Skyla. Those ones have progesterone-only hormones in them, and those can also help with bleeding. The tricky thing with the fibroid is it does depend on the location. So if you happen to have a submucosal fibroid, so a fibroid that is sitting in the cavity that also has to, compete with space for the IUD, sometimes the IUD may get dislodged or exposed because if it's a large fibroid. So we do have to be wary of that when we do your evaluation. There's a medication called tranexamic acid or Listita, which you may also hear of. It is an anti-fibrinolytic medication, so it's not a hormone like the first two. Instead, what it does is it decreases the breakdown of clots that happen inside of your body naturally when things are bleeding. So that will eventually decrease the amount of bleeding that you have with your periods. It's a medication you only take when you're on your period, just for the 5 days. Again, risk benefits, we can talk about that with your doctor, but that is one of the medications that's on our list. And then oral progestin. So things like you may hear the word agestin or Provera. Those are not as great as the IUD, but it is an option for you if we don't love a birth control pill and would rather just take one form of a hormone. It's something I have tried before, but if we're going a progesterone only route, the IUD is the better bet. The second tier of medications, we're coming outside of these types, but still treating the bleeding. They're called GnRH agonists and antagonists. Basically, what they do is down the line, they try to stop the release of estrogen, like the signaling for estrogen to come about, to again decrease the risk of bleeding. So you may have heard of the words Lupron. Also for the antagonist, something called Orion or Myfembry. Lupron has more been used to get somebody ready for a procedure, right? So it's an injectable. You try to decrease the size of the fibroid to make a procedure a little bit more doable. It can sometimes shrink the fibroid and also help with bleeding at the same time. So if I have a patient who is bleeding so heavily that she's become anemic and we're just trying to get her to a surgery, trying to medically get her cleared for a procedure, Lupron might be helpful because it can also decrease the bleeding while also trying to not allow the fibroids to continue to grow. But the idea with Lupron is we're working towards a surgery for you. Versus Orion or Myfembry, these are medications that also at the end of the line, they try to stop the estrogen from continuing to have these fibroids cause heavier bleeding. The thing with stopping estrogen is one of the side effects is a hypoestrogenic state, but also basically feeling like you're in menopause. Vaginal dryness, these hot flashes, that is something that can happen. So, what the manufacturers have done with these medications is they added a little bit of an add back therapy there. So, they will give back some estrogen and progesterone in these formularies. So, you have decrease of that hypoestrogenic feeling. So, again, like the hot flashes and the vaginal dryness and things, it decreases some of those side effects with those medications. Differences in Orion and Myfembry. Myfembry you take once a day. Orion is twice a day. Next slide, please. In terms of procedures and surgeries now that can help with bleeding, I use the word procedure because it's not like an actual incision in your abdomen or something like that. A uterine artery embolization is a procedure that actually gets done by our colleagues in interventional radiology. This is something that can help with, again, with heavy bleeding caused by fibroids. The way that this works is the uterine artery is what's pumping all this like big volume of blood to your uterus. So by trying to occlude that blood flow, you then decrease the bleeding, you decrease the size of the fibroids eventually. It doesn't happen overnight, but in time it'll do that for you. About 90% of patients report improved or resolved heavy menstrual bleeding after a uterine artery embolization, versus these bigger surgeries like a hysterectomy or a myomectomy where you just remove the fibroids. You decrease your risk of needing a blood transfusion. There's a shorter hospital stay. Oftentimes you'll go home the same day. Sometimes you'll stay overnight just to make sure pain is okay, because again, this is a surgery where we're trying to decrease the blood flow to something. So that can come with some pain. But in terms of a big surgery, you decrease risks of that. Somebody who isn't a great anesthetic candidate, who can't be under for a very long time, if it's a huge fibroid that might take a few hours to actually do something like a hysterectomy or a myomectomy, this is one of those options. Again, it's for people that do no longer desire fertility, because when you are cutting that blood supply off from the uterus, it oftentimes will make it difficult to conceive afterwards, and also, or may have some miscarriages after that. So it is truly for people that no longer wish to have children after this. And then the other surgical options, so the hysteroscopic resection, like we talked about with diagnosis, and this can often happen in conjunction together. You can do a diagnostic hysteroscopy. Hey, I found this fibroid. Now I can use my device to kind of cut that fibroid out. It's a resection device. There's many of them in the market. And in this way, I can see the fibroid. I see where it is. I use that device and I shave that fibroid off. It's a same day procedure. You go home the same day. So that's one of the surgical options, mostly only for the submucosal fibroids. Again, these are the fibroids that actually live in the actual uterine cavity. When you're talking about these fibroids that live in the muscle or in the serosa, at the outer lining of the uterus, these hysteroscopic devices aren't going to see that. So this is, again, as part of the surgical planning, we saw that you have a submucosal fibroid. This is one of the, same day procedure type things that we can offer for you. It initially has a great improvement in quality of life. And it does make sense. If it's a bigger fibroid that's in that lining of the uterus, it may not get everything all at once. You sometimes have to come for a second procedure. But it is something where, if you got to go to work in a week, this is one of those things that we can do for you and not have to take a large amount of time off. And risk benefit profile versus a large surgery like a myomectomy or a hysterectomy is much more on the lower risk side for that. There is this other technology. It's a focused ultrasound. We haven't started using it at White Plains Hospital, but we were introduced to it. Essentially, they're using this high intensity ultrasound energy it starts as a laparoscopic procedure. You introduce this device into the uterus, into the abdominal cavity against the uterus, that is providing this high intensity ultrasound energy, and it will cause what's called coagulative necrosis to the fibroid. So another way to cut the blood supply off to the fibroids in a different way, and it has been shown to have really great results. Less risks versus a traditional myomectomy where we remove the fibroid, or a hysterectomy, still considered minimally invasive. Ideal patients, again, with surgical planning, you kind of have to see what you're a candidate for. It's better if there's fewer fibroids, not ginormous fibroids, and ones that are well vascularized. oftentimes here, a calcified fibroid, meaning it's been there for some time. When you have a calcified fibroid, it doesn't work as well in this modality because it doesn't have as much of the blood flow that you're hoping to kind of cut off from those fibroids. Improvement is seen within the first 3 months. There's less postoperative pain versus the uterine artery embolization that I spoke about before, but it's not as improved of a quality of life as the uterine artery embolization. It may be one of those temporizing things that we do for you, but that's what the studies have shown. The last treatment option for those who do not desire fertility is the hysterectomy. That is a definitive therapy. I take out the uterus. There's no risk of the fibroids growing back later on after I've taken them out. About 1/3 to 1/2 of all hysterectomies are performed because of fibroids. That is a very common reason why we do these surgeries. You can do it laparoscopically, you can do it abdominally, you can do it vaginally. Again, depends on the patient, size of the uterus, previous obstetrical, gynecologic, and surgical history. Once you take it out, the fibroids don't grow back. This is more for people, we've tried the other ways, it really isn't working. Or if there's other things at play, I have these pap smears that are always abnormal. My cervix has some abnormal cells. We can take the uterus out, that takes the fibroids out. We can take the cervix out, that takes away those abnormal cervical cells. So that's one of those things that we can kind of help with two different issues that sometimes arise. Next slide, please. If we were treating more of the bulk symptoms, meaning space occupying, I feel like I'm urinating all the time, I can't empty my bladder fully, I have all this constipation, it's much the same modalities. A lot of it is going to be surgical. So the uterine artery embolization, myomectomy, meaning just remove those fibroids to make space. You make the uterus much smaller now. So it's not pushing on the rectum, it's not pushing on your bladder. Hysterectomy, like we talked about, you're removing the source. Those GnRH agonists and antagonists I spoke about in the previous section about bleeding, it can decrease the size of the fibroids in time. Same thing with the uterine artery embolization. It does take some time for that to take effect in terms of the size, but the hope is at least it's not continuing to grow. Next slide, please. Now, the treatment for people who desire fertility. I'm 25 years old. I just found out I have this huge fibroid, but I still want to have kids, right? Definitely, we're not doing a hysterectomy for you. You need your uterus. That's what carries the fetus, the pregnancy. Uterine artery embolization I talked about, that's not quite the modality that we would offer you because you are, again, compromising the blood flow to the uterus. It's not the most hospitable environment anymore. It may increase the risk of miscarriages after having one of these procedures. So we're looking at remove the fibroid somehow, some way. Depends on where it's at. If it's in the lining of the uterus, we can do it hysteroscopically. If it is feasible to do it laparoscopically, so that's the traditional laparoscopy or robotic surgery, that's one way to do it. Or if they're very large fibroids, then abdominal. We make an incision like a C-section, just remove the fibroids, place everything back. Depends when we're choosing between laparoscopic and abdominal, it depends on the number of the fibroids, the size of the fibroids, any other medical conditions or other surgical procedures you may have had to determine if that's the safest way to go. Whenever I consult patients or consent patients on a laparoscopic surgery, whether it's fibroids, a tubal ligation, any of those things, I always tell them, there is that risk of having to convert to an open or abdominal procedure if it is not safe to continue in that way. So that's always one of the risks with the laparoscopic procedures. But if it's well planned and things are in the, we're clear to go, then it could work out very well for people. Next slide, please. Expectant management. So technically, and as part of my counseling in the office, when I talk about treatment for patients, right? Medical, procedural, surgical, or watch and wait. These are more for people, like I said, we did an ultrasound. We happened to find a 1 centimeter fibroid. It has never bothered you. You have normal periods. They're not very heavy. They're not very painful. I've had no issues with pregnancies. We can just watch it. Oftentimes I'll tell patients, there's this fibroid here. Every annual exam, maybe we can watch it with an ultrasound, or you let me know if you're starting to feel different symptoms. I like my patients, I go by, your body, you're living in your body every day, 24/7. So when something starts to feel differently, that's when we can start being a little bit more investigative for you. If you are trying for a pregnancy right now, we're not going to give you a birth control pill, because we're trying to get pregnant. We're not going to do a myomectomy right now. Once you have a myomectomy, so one of those fertility sparing treatments that I spoke about before, you do have to wait some time before getting pregnant. So that is part of how we talk about this in the office. If it's a laparoscopic procedure and it wasn't super invasive, meaning we didn't have to dig super deep into the muscle of the uterus. Maybe they weren't so large. Typically, we say 3 to 6 months. You wait 3 to 6 months before you become pregnant, just for safety of the pregnancy. We did the surgery on the uterus, and now we're going to expect it to grow with a fetus in there. We would like some time for those scars to heal on the uterus. So laparoscopically, we'll say 3 to 6 months. If it's abdominal, it's probably because it was a bigger fibroid. So typically 6 months, maybe a year, but that does depend on how the surgery went and how we're healing. Other reasons for expected management, if the sizes have been stable, I've been watching you for ultrasounds for 5 years now, they're always 1 centimeter, they're not really doing anything. We don't have to treat you with something right now. If where you are in your life, now I'm 65 years old. They told me I had fibroids when I was going for ultrasounds when I was pregnant. They never bothered the pregnancy. We don't necessarily have to do anything for that. But it does involve periodic check-in. There is no standard for how often you do these things. A lot of it is individualized to the patient, and that's what you have the conversation with your physician about or your provider about. Last slide, please. So my special populations. Peri and postmenopause, I spoke on just now. Truly, after menopause, meaning the ovaries are no longer providing estrogen, and which is why you no longer get a period, the fibroid should not grow anymore, right? So that's why, depending on where we are in our lives or how the symptoms are, we may choose different ways. And also, if I have an 80-year-old person in the office, is it really safe to do surgery for them, right? So that's a lot more of a conversation depending on how bad the symptoms are. And again, a risk-benefit discussion that you have with your provider. For pregnancy, we take care of plenty of patients with fibroids. They come in all different shapes and sizes in terms of the fibroid, so they determine, how they impact the pregnancy. More often than not, we're just watching the fibroids. You get plenty of ultrasounds in your pregnancy. We're just going to watch to make sure they're not growing. As long as they're not impeding the birth canal, sometimes they are very low on the uterus. That may make it difficult to have a vaginal delivery. If they're not doing that, we watch it for the most part. But the problem becomes when the blood supply to the pregnancy is competing with the blood supply to the fibroid. So that's what I spoke about a little bit earlier. Degenerating fibroids happen a lot in pregnancy because, again, the blood supply is being rerouted in a different way. A lot of that is symptomatic management at that point. We'll have you in the hospital. I have this terrible pain. I know I have these big fibroids in there. We have you come into the hospital. We monitor the baby, and we try to get these pain medications on board for you to try to stabilize all that. It can happen at any point in the pregnancy, early, late. I've seen it all kinds of ways. But obviously, we can't do surgery for you if we are in the second trimester of your pregnancy. It's too early for that, assuming that the baby is doing okay. So that just becomes a little bit more of like a multidisciplinary approach to symptomatic fibroids in a pregnancy, again, determined by what the symptoms are for the patient. These like space occupying bulk symptoms, that's hard to fix, right? Because the pregnancy is going to continue to grow. The uterus is going to grow, plus it has this fibroid on there. A lot of it is going to be, modifying activity. Maybe we're not reaching down to the ground to tie our shoes like that anymore after a certain gestational age. Things that'll make it more pressure in your abdomen. We're going to try to find other ways to modify activities, things like that. But pain is something that I have seen. It can be pretty debilitating. So that is something that we take care of in the hospital on labor and delivery. And I think that's it. That's me. That's my face. I gave you a whole lot of information, and those are my colleagues. We're all very well versed in fibroids. We have particularly Dr. Corey, Dr. Fuwani, and Dr. Meacham on this page. They do a lot of our like robotic or abdominal myomectomies. So you may hear of them in the community. We all do hysteroscopy here. Aside from my certified nurse midwife, she's more of my obstetrical area. And then Dr. Tuberty, she's the gynecologic oncologist. She does also do some benign cases, especially if it's like a complicated size issue for the fibroids. If there's some other comorbidities that we're dealing with, we often work with her. She's wonderful. But these are all of my colleagues. We're all happy to help in all the different offices that we have with White Plains Hospital. Thank you.